Today we deal with vascular insufficiency. In all injuries of the limb, vascular insufficiency should be suspected at all contact points of the patient. It presents as pain, pallor, pulseless paresthesia and paralysis, especially if you have applied plaster. There is no reason for pain because of the fracture movement, and still the patient is complaining of pain. Then it is because of vascular insufficiency and you have to do something about it. The basic thing is you start with a less than 2-second refill after nail blanching. You blanch the nail and it should take less than 2 seconds to fill. If it doesn't, then there is vascular insufficiency. Then there may be discoloration, the bluish hue. There may be decreased temperature. These are the physical signs. Then the quantification of vascular insufficiency is done by a pulse oximeter, and the site is usually identified by angiography or Doppler. Special tests for vascular insufficiency in thoracic outlet syndrome like cervical rib or scalenus anticus syndrome is Adson's test, where you abduct and extend the upper limb 30 degrees from the shoulder, palpate the radial artery, ask him to move the chin towards the same side and extend the neck. Ask him to take a deep breath and hold it, and you will find that there is a remarkable decrease in the pulse volume, and the pulse volume may disappear in thoracic inlet syndrome. You must always compare it with the opposite side. The second test of vascularity is Allen test, where first you ask the patient to make a fist so that there is blanching. Then you occlude both the radial and ulnar artery and then leave them one by one, and you would find the blanching is usually reversed in 8 to 10 seconds. Now, if the ulnar artery is competent, then you can use the radial artery for coronary angiography or other purposes. So that's where this test is usually used. Now, when the patient comes to you, supracondylar fracture, flexed casted upper limb, flexed at elbow, and what you find is that there is pain, pallor, pulseless paresthesia, paralysis, and 2-second nail blanching is positive, then what should you do? The first thing is remove all external pressures, extend all joints, grossly reduce all fractures and dislocations. Check again. If still the circulation is not returned, then elevate the limb after a sumac strapping, because there is an edema ischemia cycle. The edema, because of the injury inside a closed facial compartment, causes an increase in intracompartmental pressure above the arterial pressure, so the arteries can no longer supply the blood. Because of that, the vessels in the muscles become leaky and there is more edema. So edema, hematoma inside the closed facial compartment leads to what is called as the edema ischemia cycle and must be managed. So elevation of the limb, sumac strapping, active movements are the first step to try to do this. But if that fails, then you have to do a fasciotomy. And you would appreciate that this is the tibia, this is the fibula, the anterior border, the medial border, the lateral border of the tibia with the anterior, lateral and the medial border of the fibula, the interosseous membrane, The anterior compartment, the peroneal compartment, and the deep compartment is divided into the superficial one, in which there are the soleus and the gastrocnemius, and the deep one in which there is the tibialis posterior. So what you do, if you remove the fibula, then all four compartments are decompressed. So fibulectomy is a very good way of doing decompressing the compartments in the lower limb, in the leg. Check again. Till then, you should have started complamina, you should have started alpha blockers, you should have given anticoagulants like disperine or percentin. And then if that is not there, you block the sympathetic supply of the upper limb by blocking the stellate ganglion. You recognize stellate ganglion block by Horner syndrome. Check again. If not, convert the stellate ganglion block into a brachial plexus block. Explore, reduce and retain all fracture and dislocations before you start touching the blood vessel. Then you explore the artery, you go from the pulsating to the non-pulsating part to find out the site of lesion. Remove all external pressures. For spastic segment, first try to sprinkle xylocaine and see whether the spasm is relieved and the pulsations come back. If not, do a proximal arterectomy. You do it obliquely with a beveling, because you don't want the fibrosis in the V-suture to cause an arterial stenosis. You have divided the adventitia, you have divided the sympathetic plexus, you have divided the artery, but you have resutured the artery, but the sympathetic supply to the spastic segment is gone, and it is expected that the spastic segment will dilate. You can use stenting also to dilate the spastic segment. Otherwise, you will have to resect the spastic segment and replace it by a reverse vein graft, so that the walls are in the correct direction of flow. If there is a thrombus inside, put in a Fogarty catheter, dilate the balloon, remove the thrombus and heparinize the vessel. So radiology can do it with closed arteriography, and radiology can also do stenting with angiography. So now there is a huge advance in the technique of restoring blood supply to a ischemic limb. If you have failed, if the patient has come too late, then there is gangrene. In gangrene, the basic thing is that there is myoglobulin which will go to the kidney and cause renal failure. So you should look for renal failure. Then you should do a amputation, first a guillotine, and then the open amputation where you have flaps but you don't close them, and then the closed amputation. You should know the indications, you should know the labels in the classification of various amputations, you should know about immediate post-operative prosthetic fitting, and you should also be able to do it. Why you wait 6 to 8 weeks before taking the measurement for the final socket is to cause maturation of the muscles, because the muscles will shrink and the prosthesis will become loose if you take it before that date. Then what are the types of prosthesis, how to prescribe a prosthesis, how to do dynamic and static alignment of the prosthesis, how to gait train, all these things you should know. But amputation is a separate chapter, and we have covered vascular insufficiency in this class.